that. These are our suicide guidelines by IAP as well as STG guidelines. Everything is mentioned in that. So recommend the parents to be connected, be empathetic, give help, don't have a stigma feeling. School, you teach the teachers. Health system should be also very robust. So what we understood is suicide is a major public health problem. 12.4% is not a low. So let it be, it is a preventable. Most of the cases it is preventable. Sometimes it may not be, but we can help for that by inquiring proactively, recognizing warning signs, timely referral, life skill training, and as a multidisciplinary team providing national helplines. Follow-up should not be forgotten, medications when it is required, restrict the means. Everyone has to role play with responsibility to prevent suicide. So IAP, AHA both have got a role to play. So what is Ray of Hope? Join the movement and make as a mission to safeguard the mental well-being of India's youth by building compassionate support system, promote the awareness and enable the early intervention, empowering every teenager to choose life, hope and healing. Suicide is a preventable condition. World Suicide Prevention Day has to create awareness, not on that single day, every day. So these are my references. Thank you very much.
Any questions? Thank you, ma'am. Thank you very much. I request Dr. Shuganti, ma'am, to deliver the memento to Dr. Geeta, ma'am. Thank you, ma'am. Next session is on pediatric pulmonology in practice guidelines versus ground reality. I welcome Dr. Kala Raghu, ma'am, moderator. Panelists, Dr. Madhusudan, Dr. Rajesh, and Dr. Raghupati. Please welcome, sir. Dr. Kala Raghu, ma'am, is a senior pediatrician. She is from Karpagam Faculty of Medical Sciences. Her areas of expertise are medical education, developmental pediatrics, and adolescent health. She has got a 29 years of experience. Over to you, ma'am.
Good morning to all of you. I guess it's good afternoon to all of you. We've reached just the last concurrent session for this whole KONGU PEDICON. So I'm sure all of us at the end of our tether, we all want to move out. So we promise to keep the whole session crisp. We'll promise that we'll not run over time. That's something which we'll do. And we'll also keep it very practical. So first of all, let me, on the behalf of all the panelists and myself, thank the organizing committee for giving us this opportunity. And also congratulate the whole organizing team. It has been such a fantastic 3 days. Great academics, great networking, and ultimate use of technology. So congratulations to the whole team. So today's topic for us is pediatric pulmonology, the guidelines versus ground realities. And as all of us practicing pediatricians know that we all know the guidelines, but are we able to follow each and every part of the guideline? What are the challenges which we face, and how do we maneuver around these challenges? That is the scope of today's session. Before moving on to the first case scenario, we are taking some 3 case scenarios, very common ones. So let me first introduce the panelists. We have Dr. Rajesh, professor from PSG College, Medical College. Sir is a senior clinician, academician, and I think most of us know here a teacher who's very well sought after. So welcome, sir, onto the board. And then we have Dr. Raghupati. Dr. Raghupati is so you have your fan association here. So we have Dr. Raghupati, who is a senior assistant professor from Government Teni College, Medical College. Sir also is doing a fellowship in asthma and immunology, so a right person to be on this panel. Welcome on board, sir. And then we have the young and dynamic Dr. Manoj Madhusudan, and he is an interventional pulmonologist working as a consultant at RK hospitals, as well as he is in Ma Kaveri, Trichy. So shall we move on to the first case, sirs? Okay, fine. So we have a case scenario of a 5-year-old male child who's presenting with a 2-day history of dry cough. There's no fever. The child has got exposure to construction dust. That's the history given. And on probing the parent, the caregiver says there has been similar episode in the past. One episode 2 months back where the child improved with nebulization, responded well. But at that point, no other treatment was advised to the child to take at home. And then there is a family history of asthma. And now we have the child who's presented to us with tachypnea. And on auscultation, the child has got bilateral bronchi. So, Raghupati sir, can you tell me how would you like to manage this child if the patient presents to you in the OPD?
So, good morning everyone. At the outset, I thank the organizers of the KONGU PEDICON for giving me this opportunity. So, coming to this case, this is a child, 5-year-old child with, ma'am, previously. Case.
Okay.
So, 5-year-old child, now coming first time to the OPD with tachypnea and bilateral V's. There is a history. Previously, there was an nebulization, and the father is a known asthmatic. So according to the guidelines, 2025 GINA guidelines, first we have to, any under 5 V's, whether it is asthma or not. That is the first question that arises. So the first question is whether it is an asthma. The 2025 guidelines gives a clear answer for this question. Previously, there was a probability-based classification. Nowadays, we have, in the 2025, they have clearly given that under 5 is, if there is, the child fulfills the 3 criteria, then only we can call it as an asthma. So what are the 3 criteria are? The first criteria is there should be an acute recurrent V's. So acute recurrent V's, the previous slide, ma'am. So any 2 episodes of V's, of that, in 1 episode there should be an confirmed V's. So that we can take it as an acute recurrent V's. So the first criteria is fulfilled here. The second criteria is there should not be no other diagnosis is contributing to these symptoms. So for that you have to have a detailed medical history and examination. And the third is a timely response to the asthma treatment. Either it's an acute treatment or it's a chronic treatment, a timely response. Here we can give a bronchodilator. For the bronchodilator, if the child responds within minutes, or if it's very severe, if response within 3 to 4 hours, then we can take it as an asthma. So that is the third criteria. All the 3 criteria should be filled. In this case, we presume that there is no other diagnosis, and if there is a response to the bronchodilator, we can take it as an, so we can give a bronchodilator and see. So how to manage this case? So according to the scenario, it is a mild flare-up. So for a mild flare-up, you have to give a salbutamol, 4 puffs. We have to see the response after 20 minutes. And if the child needs, you can repeat the 4 puffs 3 times. And if the child doesn't respond or show some improvement, but still the child is having some V's, you can add ipratropium, and also you can start oral corticosteroids. So this is how we are going to manage, and if it is severe, we have to go for oxygen. Oxygen saturation should be maintained more than 94%, and you can go for an IV steroids. And you can start an IV Maxelf. So this is how we are going to manage this.
Okay, thank you. So here there is a clear mandate, so as sir has said, we follow the GINA guidelines as far as possible. So what, according to you, could be a challenge when it comes to following the GINA guidelines, especially a child who's coming for the first or the second episode? And would you want to start the child on MDI with spacer, or what are the challenges which you face?
So the challenge first, establishing the diagnosis. So for that, the current guidelines is very much helpful, and we can go for that. And if the child doesn't fulfills these criteria, we can give a trial and see. And by the time, due course of the disease, the child may fulfill the criteria. The next challenge is convincing the parents for spacer, especially if they are coming for the first time to you. Because accepting the diagnosis itself is difficult, and convincing them for the spacer is a real challenge. But given the advantages of the spacer, because with the MDI with spacer, the drug delivery is in the airway, it is around 10 to 20%. Compared to nebulizer, it gives only around 5% of the drug will be delivered into the airway. And the oral deposition with nebulizer is around more than 50%. But with MDA and spacer, it is less than 10%. And the risk of infection with the nebulizer. And also, the home, after discharge, what you are going to do? This case you can manage with the nebulizer in the clinic. But after discharge, giving an oral bronchodilator, once again, it may not serve the purpose, because the absorption is erratic and the child may end up in the midnight flare-up. So you have to try, and it is our duty to convince them for the spacer, not only for the management in the acute setting, but also the discharge and follow-up. And in my experience, if you are giving a spacer for a child with a flare-up, and they are seeing the response to the spacer, and if they are convinced with that, then definitely they will follow it.
Okay, I think pretty much all of us practicing pediatricians will agree to this, that spacer is a bottleneck when we decide to put these children on home-based therapy. Now addressing a white elephant in the room, which is home-based nebulizer. If many of us might not have Insta accounts, but most of our patients somehow seem to have nebulizers at home. And most of the patients are asking, "Veetukku poi nebulizer pannalama?" This is a very common question which all of us are facing. But Rajesh sir, can you please address this elephant in the room about home nebulization?
Good afternoon, one and all. This is actually a real menace now. Like we have online portals which sell nebulizers. We have respules being sold as over-the-counter drug. So often our patients misuse this therapy, which is intended to be given only in the hospital setting. So what are all the risks that are involved in home nebulization? Most of the things you know. Many times during the parents might not recognize the severity of the condition, and they might nebulize at home during the acute phase, and this causes a lot of mismatch in the ventilation and perfusion that can actually worsen the hypoxemia which the child will be having during the acute severe phase. Number two is a lot of risk about the cardiac arrhythmias we tend to overlook. These children go for tachycardia. Sometimes they also have develop arrhythmias, and which is sometimes become fatal also. Third, the parents, how they are going to decontaminate the tubings, and all these things are factors which are strongly against advocating home nebulization. But in reality, that's in spite of us having a clear guidelines against use of home nebulization, but still in practice, we see a lot of parents, as you have mentioned, ma'am, that they tend to have these nebulizers at home and tend to abuse the treatment. So I think at every visit we should ensure that this practice is we should speak against such a practice. The risks involved should be reinforced to the parents, and as a society, as an academy, our academy, we also should focus more towards some guidelines online sales of these things, these nebulizers, etc. So that there is a check on sale of respules as well as nebulizers. It can't be like a commodity which everybody can purchase and use it without any medical supervision. So that's my point, and strictly no for home nebulization.
Okay, I think point well taken. Home nebulizers are a no, and maybe summarizing this whole case scenario, if you have a recognized bronchial asthma case, we should utilize every contact with the patient to give patient education regarding the importance of using spacer and MDI and compliance towards that, which will actually help us in having a better control of asthma. Is that right? Yeah. Okay, now moving on to the second case. We have a 13-year-old female who's come with a history of fever for a week, and she's developed 3 days cough and left-sided pain along with some difficulty in breathing, all that very short duration, a day's duration, and now she's got 2 episodes of blood-tinged sputum. The parents on probing say there is an undocumented weight loss, and there is also a past history of asthma in this child. She's been on inhaled corticosteroids, and in the last 2 months she's self-discontinued the treatment. The father is a known case of tuberculosis, treated a year back. He's completed his whole course. He's doing well, rather well. When on examination, you see that the child is thin-built, she's pale, and she's having saturations which are a little low. There is tachypnea. And summarizing, she's got decreased air entry on the left side along with stony dull note and bilateral rhonchi as well as crepitation. So this is how a child, 13-year-old female with a short history, with some past history of asthma and a family history of tuberculosis has presented. Rajesh sir, would you like to tell me how the child is coming to you the first time, no other treatment taken for this episode, how will you like to treat?
So the index patient, the child has come with acute respiratory infection, probably like a community acquired infection. So this child has to be started on antibiotics, appropriate, like being a community acquired pneumonia. As per the recommendation, we are going to start empirical antibiotic, and we'll have to watch for clinical recovery. It's very well known that community acquired pneumonia can be complicated with pneumonic effusion or sometimes empyema. The red herring here is we have contact history of tuberculosis, and number 2 is there is hemopsis, which in Indian scenario is often in children is associated with tuberculosis. So whether how the child should be treated, number 1 is to start on antibiotics, broad spectrum cover, and watch for clinical response, and then move on as the disease evolves. That would be my plan first.
Okay, fine. So let us take this situation further. This patient, you put her on an antibiotic, the appropriate one, the right dosage. You kept her under follow-up, and you now see after day 6 or day 7, she's not actually improved. Her air entry is still low. She seems to be not doing so well. Her stony dullness is persisting. You did a repeat X-ray, and you found that there is the same left-sided homogeneity, homogeneous opacity, which is seen as in the previous X-ray, and the ultrasound also shows a effusion. And you put in a needle, did an aspiration, pleural aspiration, and this is how the counts look like. Polymorphic predominance with an LDH which is about 3 to 4 times raised as compared to what would be normal. Sir, now with this situation, that means you have given the antibiotic, you have given the right dose and whatever, and you've done the basic cultures and bacteriological investigations. Now you have a child who is not improved. There is a family history of tuberculosis. There is also some undocumented weight loss. What would be your next approach? Will you now try to aggressively identify whether this could be tuberculosis? How would you approach this child, sir?
So we have many factors to consider the possibility of tuberculosis now after the evaluation, and also the poor therapeutic response, which I would say, like in spite of a broad spectrum antibiotic cover, the child is not responding, still having worsening of the pleural disease. And we have, it's the time that we have to start actively looking for tuberculosis in this child. And that is also what is given in the NTEP guideline. The child who is having persistent fever or persistent cough with some weight loss, or there is a positive contact with tuberculosis, all these things we are supposed to evaluate for tuberculosis at that juncture. But whether at the admission itself I will evaluate for tuberculosis, I would say no. But after a good therapeutic trial and still the child is not showing any clinical response, I think we are justified in actively looking for tuberculosis, evaluating for it, and then we'll have to treat it. In this case, if you have seen the pleural tap, everything is pointing more towards a bacterial infection. Again, the classical situation we all see, like we believe it to be a bacterial pneumonia and its complication, but still sometimes tuberculosis can present as an acute disease also. So I will actively look for TB, do a MAN2, tap it, send the fluid for routine analysis as well as for CB-NAT, and induce sputum for CB-NAT again, and I will wait for the results and then decide.
We all know that paucibacillary dysentery is more common in children. Maybe she is a little older than a child, but if it was a younger child, so we have this problem when we are doing, we are not unable to get the right specimens. The MAN2 sometimes equivocal, we are not able to really confirm. So in such case, how will, suppose, let us imagine this child, you didn't find any evidence of tuberculosis, but she's still not improving, you're not really satisfied when you discharge her. So what would you do next to see that this child doesn't get lost to follow up and we actually end up treating her and she improves? So what will you do?
So as you have mentioned, ma'am, this is the common situation which we often see, like we are unable to have a microbiological evidence of tuberculosis always. So we tend to knit up all the clinical findings and the laboratory findings to make a diagnosis of tuberculosis or to disprove the diagnosis. So the greatest challenge is not the technique in which we are going to make the diagnosis, but actually how we are going to obtain the sample for establishing a diagnosis of tuberculosis. Getting a gastric aspirate, if it's a young infant, gastric aspirate for tuberculosis evaluation, or induced sputum, all these things, the yield is extremely poor. So though these CB-NATs are having very high specificity, but still the yield from these samples are poor, so it's really difficult at some point whether we should treat or do not treat. So here we have solid evidences to say that it can also be tuberculosis, like the child has presented with an undocumented fever, hemoptysis is there, positive contact is there, and we don't know whether the child was on some home inhalers or nebulizers, which again, for the asthma, if they are going to give steroids, that can also be a factor for developing tuberculosis. So whether I would treat will depend on from which setup the child is from. Is the child is from a place where I can have a proper follow-up and I can reinvestigate the child if the child is not is not showing proper response for tuberculosis, or is it a child who is from a remote place where I can't exactly follow the child properly. So if it is like a poor to follow up child, I might end up starting ATT for this child and attaching them with the program and being followed up by the government facility. But if they are from an urban setting and the parents are well informed and they are willing to come for follow-up, probably I will actively look for getting a microbiological evidence for tuberculosis and then treat only if I have an evidence, otherwise I will tend to follow up this child. So
Okay.
it depends
Rather
on.
than urban, rural, I think it's more of their accessibility to medical services as
Yeah,
well as
yeah,
the
that's what I
yes,
meant.
yes,
That's
yes,
what
sir.
yeah.
So now sir is again in some kind of a dilemma. So Manoj sir, Dr. Manoj, would you like to tell us as an interventional pulmonologist, are there some methodologies which we can use so that the yield is better and we have more definitive conclusive diagnosis? Do you have something up your sleeve?
Yes, madam. So again, going through the NTEP guidelines of later years, there is a clear-cut shift towards a microbiological confirmation of tuberculosis. I mean, 20, 30 years back, any child with a cough was technically thought of as tuberculosis. And once X-rays were more available, any pneumonias that are not responding were generally thought of as tuberculosis. Now with the expanding armamentarium of investigations and with improving subspecialty care, there are a lot many investigations that we can do to either diagnose or rule out tuberculosis in scenarios. One of the most difficult challenges, I mean, even as a PG, while going through cases was pleural TB. Because what was generally taught to us was pleural TB is a reaction. It's not actual TB. It's a hypersensitivity reaction. That is false because again, even in pulmonary TB, it will be difficult for us to get samples, say gastric aspirate or whatever it is. Pleural TB, getting a proper sample was very difficult. That is why it was, I would say, falsely termed as just a reactionary thing. What we generally do in these scenarios where the child has an effusion, you have a doubt whether it's infective, regular bacterial infection, TB or something else, we have something called a medical thoracoscopy or a pleuroscopy. So this is just like inserting an ICD tube. Basically you go in through an ICD port. We have something that looks very similar to a bronchoscope, but it is used to access the pleura. With this, we can get biopsy of the parietal pleura. And with this we can prove tuberculosis, prove or disprove tuberculosis. How drastic it is that there are only few studies on medical thoracoscopy in pediatric pleural TB, one of which was from the center which I was trained in. Pleural fluid has a sensitivity of 5 to 15% for microbiological confirmation of tuberculosis. Whereas with a pleural biopsy using a medical thoracoscopy, it is more than 90%. The image that you see is classically called as agograin follicle. This image alone for me would be diagnostic of TB.
Okay, so we have right from the horse's mouth, if the patient is affordable, there is access to specialists like Dr. Manoj, then we should definitely try to use that facility before we give a trial for ATT. Is that a right conclusion? Okay. So moving on to the last case, I think we are very much in time. So we have case scenario 3, where there is a 8-month-old child who's presenting with a 1-day history of fever, and the cough started 4 days back and it's been progressively worsening, and now the child has presented to the OPD as a child with fast breathing. There's a previously well child, there's nothing significant in the antenatal or the birth history, and child has been thriving well, and now there is a only history is URI in the elder sibling. On auscultation, you see that the child is tachypnic and he's got bilateral crepitations. Now, Manoj sir, would you like to actually, this child is coming to you with tachypnea and bilateral crepitations and 8-month-old child. So what would you empirically take as a diagnosis, and would you like to give salbutamol in this child as the patient comes to you like this? This is the first question.
So conventionally, any child coming with the first episode of lower respiratory infection with a typical viral sort of a history, the traditional diagnosis is bronchiolitis. And what we've been taught right from our UG days is that, okay, I mean, younger children, beta-2 receptors will not be there, bronchodilators will not help in bronchiolitis. You should ideally do nothing as per evidence, or at best you can give 3% saline, which helps in a bit. So, I mean, to put it up more practically, it is difficult just with the history and clinical examination to say if it is bronchiolitis or wheeze. What I'm trying to say is that wheeze is generally considered as bronchoconstriction, whereas bronchiolitis, the pathophysiology of the distress is secretions in the airway. What we are trying to say when that, by saying that 3% saline helps better in bronchiolitis is that if there are only secretions in the airway and not actual bronchoconstriction, your bronchodilators may not be of much help. You use something like hypertonic saline, which helps in airway clearance. Whereas if bronchoconstriction is the basic pathophysiology of the distress, your bronchodilators are supposedly superior or obviously superior. So in a child, say an 8-month-old coming to you, there is some crepitation. If you dig into the history, the sibling would have had nebulizations in the past. You really do not know, or you cannot confidently tell from your clinical examination that it is only bronchiolitis or there is an element of wheeze. So if in a similar scenario, if a child comes to my OPD or emergency or whatever, first thing I would do is give a trial of bronchodilators. I give something like salbutamol or levosalbutamol, say 2 to 3 times back to back, and assess response. If bronchoconstriction is the predominant pathophysiology, you will notice a response. You will notice a significant response in the distress, cough, hypoxia, everything. So if that is the case, I would treat this child similar to how I would treat any other wheezer. So I would put all my focus on bronchodilators. I would add maybe steroids. Treat the child like I would treat any older wheezer of that sort. However, even after say 2 to 3 nebulizations, I do not notice any significant response in the child. I would tone down on the nebs. I would just give 3% saline, focus more on oxygen, focus more on high flow nasal cannulas if things are required and things like that.
Bronchodilators, like traditional bronchiolitis.
Traditional way, rather than pumping the child in with bronchodilators or steroids or those sort of things.
So bronchodilators are not a no-no. You can give a trial, see for response. Depending on the clinical response, you can decide whether you want to go this way or the traditional bronchi. Is that fair enough?
Exactly.
Okay. So we always have this debate about hypertonic saline. We all use it right, left, and center. Is there some evidence saying hypertonic saline actually helps? Yeah.
So
is there some evidence?
actually, Cochrane comes up with a yearly review saying about the use of hypertonic saline in infants with bronchiolitis. So I remember when I was doing my PG, there was a 2016 guideline, 2018 guideline, 2020 guideline. All of them said that hypertonic saline doesn't help or there is no noticeable difference. However, the most recent one, the Cochrane review from 2023, it has looked at hypertonic saline versus conventional treatment in bronchiolitis. And across almost 2,000, 3,000 infants, what they found is that hypertonic saline does reduce hospitalizations. What this means is, say the child comes to the emergency room with cough and distress, you give 1 hypertonic saline, it reduces hospitalizations, it reduces the length of hospital stay by almost 1 day, and they've looked at distress, respiratory distress immediately post nebulizations. They have noticed a significant decrease in respiratory distress post nebulization. So at least as per the recent review, hypertonic saline does help in children with acute bronchiolitis.
So you will tell us that we've all been doing the right thing for the
We've
last
been doing
few
the
years.
right thing, knowing or
good.
unknowingly, madam.
That's a good one to listen to. Okay, and just before we move on to the last part, you being a super specialist, do you use PCR commonly, and where do you use PCR? How often do you, what are the indications for you doing a PCR in such children who come to you?
So if cost is never an issue, I would do PCR analysis for all children, madam. Okay. So the main indications is that, see, I mean, in the preceding talks, we were told that there was an epidemic of adenoviral infections a couple of years back. Last year, there was a surge of mycoplasma infections. These we get to know only if we start screening. So you take adenovirus or even mycoplasma or any virus, COVID for that matter, they present in a very similar way. There'll be distress, there'll be some infiltrates on the X-ray. You really can't find a difference. So if cost is not an issue, I would say screen every child. However, being in India, cost is always an issue. If you want what I would say, a more effective way of screening where you factor in the cost, also you factor in the treatment and other things, I would put few scenarios where PCR testing is a must. One, any child that goes into the ICU, I would say you have to test PCR. Because there are certain infections that we can treat, there are certain infections we can treat in certain scenarios. like mycoplasma, mycoplasma presenting as a similar bronchiolitis, say you find a PCR evidence, you can start treatment, or you can be a bit more confident in your treatment. So mycoplasma, what we've been finding in the last year is that they're not responding well to azithromycin. Sometimes we have to give in steroids. So a child with the consolidation on the X-ray, in the ICU with distress, you wouldn't be really confident giving the child steroids. Whereas if I have a PCR diagnosis of so-and-so, I would confidently give steroids. Any immunocompromised children, I would strongly recommend PCR testing with an event of LRA, because there are a lot of mimickers. Say PCP will present more or less similar to your viral infections. Even conditions like adenovirus, there are medications which we do consider in immunocompromised children. True. So any child in the ICU, any immunocompromised child, and during epidemics or pandemics like what we have in COVID, I would say we should be more pushy towards a PCR diagnosis. If not scenarios outside of those, if cost is not a factor, we should definitely try and do a PCR testing.
Okay, fair enough. Raghupati sir, last slide for the last question for the panel this time is, are there some, would you like to tell the PGs and the ones who are going to start practicing now, what could be the red flags they should look for in bronchiolitis, and what would, according to you, be the indications for admission in such patients?
So yes, ma'am. So before going to the red flags, we should know that why we should know the red flags. Because bronchiolitis, it presents with a very spectrum, and mostly it is a self-resolving disease, but we do see that a certain proportion of the children will come with a very severe spectrum. Yeah. And we will be, when go by the general history, when the general pattern in the bronchiolitis, it is a disease for around 3 to 4 weeks, but the first week, in the first 2 to 3 days, when we see it will start with only the rhinitis, it's like a general normal URI, or sometimes with some tachypnea. And if we are sending the child home, we have to advise them, because the worsening happens in the end of the first week. When we see the graph, at the end of the first week, the child may go for increased distress and other hypoxemia. And then the cough may persist up to 18 days to 21 days. So when we are sending the child with the parents, we have to advise them to look for the red flags. So the red flags are, is there any worsening of the distress? And how about the oral intake of the fluid? If the fluid intake is less than 50%, and how is the urine output? We know that asthma, bronchiolitis, everything may have a component of SAIDH with them. So how is the decreased urine output? And younger children, they may have apnea instead of a tachypnea. So is there any apnea? And the most important thing is whether the child is playful. The child, bronchiolitis child, if you see the mild cases, the child will be having a tachypnea, but child will be looking around playful. But if the child is exhausted, child is not responding to the social cues, these are the red flags. So is there any worsening of the breathing? Is there any decreased fluid intake or a decreased urine output? Is there any apnea or child is exhausted? These are the red flags we have to see. Coming to the admissions, any red flag you have to admit. And the younger child, if it is less than 3 months, it's very difficult to, as I already told, the child may end up in apnea and child may brought very sick. So any young infant less than 3 months, it is better to admit, and especially in the first week of the illness. And any high-risk children, any congenital heart disease, chronic lung diseases, any neuromuscular diseases, known immunodeficiencies, bronchiolitis is a very severe disease. And social circumstances, if the child, if we are not able to follow up and the parents are not able to look for the red flags, and they are coming from the remote places, these are the indications for admissions.
Thank you so much. It's been really very clear for everybody. So this is the last case we were planning to discuss. So we have a few take-home points. The most important would be, as far as the first case is concerned, is every time we have an opportunity to see an asthma patient, we should utilize that particular opportunity towards patient education regarding spacers, MDIs, their effectiveness, their necessity to take them with compliant manner so that school absenteeism becomes lesser, their admission number, the number of admissions become lesser. And nowadays we are all in this Insta and reels and shorts life. So we can actually make educational videos which are less than 1 or 1.5 minutes, so that the patients actually get to see in a manner which is more palatable to them, because that is something they consume largely. And you can also have WhatsApp groups created for your clinic or your private patients, and share these educational pamphlets AV material to them. That would be helpful. And it's very important to ensure that the patient is going to be compliant. There's no point in starting the medication without any assurance that the patient is going to be compliant. That's one of the first take-home messages. The second, as far as the community-acquired pneumonia with a background of TB could present even with an acute short history of about 10 to 14 days. It is not always that it has to be a longer duration TB. And we all know that in very young children, the non-cavitatory forms of TB are very common. So hemoptysis or any of the other things might not be evident. And if the parents are not very sharp, fever could be missed. So weight loss in a family history of tuberculosis, non-responding to the conventional course of antibiotics, even after maybe stepping up the antibiotic, would warrant to at least aggressively investigate this child for tuberculosis. And as Rajesh sir had rightly pointed out, if there is a chance that the patient would be completely lost to follow up and there is an overwhelming evidence tending towards tuberculosis, we might be justified in starting. And if we have Dr. Manoj around, then we can send him for a pleural biopsy. Yeah. And finally, bronchiolitis, which we see, and this is like the season happening all over the place. In another couple of months, we'll be seeing quite a bit of bronchiolitis, at least in this part of the state. Trial with bronchodilators under close monitoring, watching out for tachycardia, and should be done under close monitoring. If you see that the child is actually improving, if there is a clinical response, we are justified. Otherwise, we have our old friend, hypertonic saline, which we've been using for ages, and we can continue to use that. So would you want to say something else, or is that, yeah? So thank you so much for the patient hearing, and thank you very much.
Any questions? Any questions?
If there is a radiological finding on the X-ray or the CT, then I would do a BAL, madam. Say if X-ray is normal, there's only an effusion. I mean, parenchyma is normal, there's only an effusion. Or X-ray is normal, but the child has cough and fever, you're thinking TB. The yield from a BAL is very, very low. Whereas if you have an X-ray lesion, particularly TB-specific lesion, something like cavity or this one miliary pattern, then the yield is very, very good. Without an X-ray lesion, there's no point asking for a BAL.
Actually, the third day of Pedicon, the fag end of the session, it was really very beautiful session. I enjoyed it very much. Thanks to the moderator, thanks to the panelists. Actually, I had a doubt about BAL, and you have clarified. So how often you do BAL for tuberculosis in children?
That is what, madam. When you have CBNAT, which is done free in a government-like institute, I would say first try with a less invasive sample, gastric aspirate or induced sputum, and if that is positive, well and good. In the private setting, it is a bit tricky because your gene expert is again 3,000. You can't do a gastric aspirate, send it for a 3,000 investigation, negative, do a BAL, send it for. So I would be a bit more earlier on BAL in a private setup. Whereas if you are able to get a CBNAT free of cost, I would say first try with a less invasive sample. If it is negative, then you can go ahead with BAL.
But BAL, the yield is much high.
Better.
And you showed a very good slide about the pleural biopsy picture.
Yes.
Thank you.
Thank you.
What is your take on TB with only a hilar adenopathy. Like children are coming with suspected tuberculosis, no pulmonary lesions, only node is being there. Because this is a very common question, because here also yield may be low. So any other alternative you have?
Yeah, we do something called an endobronchial ultrasound. So again, TB node, your yield from your lung lesion from a ball will be very, very low. So there we do biopsy directly of the node. We have something called an endobronchial ultrasound, where we use an ultrasound which is attached to the bronchoscope, scan the node, do FNAC of the node bronchially, and we can send that sample for analysis. So that should be done rather than just ball.
That actually, I know one of you've been doing the EBUS also. So I just want to put this word, because many times we think that children with hilar adenopathy, the yield will be good in the BAL sample, but actually it is not. And it's better to go for the semi-invasive procedure like EBUS. So where the yield is quite very high and we are pertaining to the treatment. And always being, as empirically, we are being starting on ATT. We are seeing off late, we are seeing a lot of children with resistant tuberculosis also. And many patients are on resistant tuberculosis. It is like a long regimen, lot of issues are being there. So better to yield with a EBUS. And people are doing currently, so we can make use of it. Thank you.
Yeah, now with a lot of pulmonologists coming up, we are doing EBUS as an OPD procedure also. Not in children, but in older kids for
Adults,
sure. Not
it's a
in young.
daycare procedure.
Adults for sure, even in older adolescent children. Yeah. So thank you very much. Thank you.
Thank you, ma'am and sirs. Now I request Dr. Kala Raghu, ma'am, to hand over the mementos to our esteemed speakers. Now I request Dr. Rajesh sir to hand over the memento to our chairperson. Thank you everyone. I think for the past 3 days, Bhavani Hall was flooded with science. I thank each and everyone here, and also I thank the AV team for their excellent cooperation. Thank you. We shall move to the Sirwani Hall for the valedictory function.